Hi, my name is Anu Verma and I am an FNP student with a US university. I am here to present my OBGYN case today. Subjective assessment, RW, date of birth 1/1/1957, 65-year-old Hispanic female, came to the clinic alone. She is a reliable source of information. Chief complaint, I think my UTI has recurred and it is very itchy. HPI, RW is a 65-year-old white Hispanic female, came to the clinic complaining of itching in her vagina, which started 1 week ago. She reports that her urine feels hot. She's diagnosed with UTI 2 months ago, but reports that she's feeling now different. She reports on and off lower abdominal pain, which rates 4 to 10. She has a white thin vaginal discharge which smells like fish. She has tried different kinds of soaps which does not relieve any symptoms. Itching is mild to moderate, experienced more at night, and it goes away on its own. Urine analysis on 3/3/2022 revealed pus cells 3 to 5 per HPF. Past medical history, diagnosis of UTI 3/4/22, and was prescribed sulfamethotrexate 800 milligram BID 3 days. Medical problem list denies any. Surgical history denies any. Allergies denies food, drug, and environmental allergies. Multivitamins, 1 tablet PO is her daily medications. Chemical history, no smoker, denies use of illicit drugs, drinks only 1 glass of alcohol per day, no coffee, and drinks no energy drinks. Immunization status, she's current in all vaccinations, including HPV and flu. She got her dose of COVID vaccine completed at 7/21/21. Gynecologic menopause LMP to 16/2005. Last pap smear 7/2019 without abnormal findings. Menarche at 12, first intercourse at 15, number of sexual partners 2, obstetric G1P1. Family history is not pertinent at this time. Social history, RW is working as a consultant. She earned her college degree in business administration and finance. She's married and lives a peaceful, low home life with her husband. Sexually active and does not use condom. Denies pain during intercourse. Religious and is Roman Catholic. She's always wears seat belts when she's in the car and does not have any guns at home. ROS, constitutional, denies fever and weight loss. Cardiovascular, denies chest pain and heart palpitations. Respiratory, denies cough and wheezing. Genitourinary, reports burning sensation when peeing. White discharge coming out of her vagina that smells like fish, itching in the inside of the vagina and outside, denies any pain on urination or urinary incontinence. Neurological, denies headache or blurry vision. Objective data for all vital signs are normal. And laboratory findings done on 5/6/2022. Urine dipsticks negative. Physical exam, constitutional. RW is well groomed, well nourished, and maintains good eye contact. Afebrile. Cardiovascular, RRR is S1 and S2 sounds heard. No peripheral edema. Respiratory, lung sounds are clear in all lobes. The pelvic and vagina exam, no vulvar swelling, no vaginal rash, revealed white thin watery discharge with foul fish odor. A vaginal swab was obtained with microscopic exam. Wet mouth test, whiff test, swab performed to wet mouth, to whip amine test, glue cells test, vaginal pH test. Wet mouth, glue cells present, pH 5.2, positive whiff and amine test. Neuro alert and oriented. Speech is audible and clear, steady gait. Assessment, differential diagnosis. Bacterial vaginosis, N77, due to thin white vaginal discharge, which is fish-like odor, and vaginal itching in and outside the vagina. Burning sensation when urinating. History of presence of clue cells, and pH is positive for whiff cells. Vaginal candidiasis, B37.3 due to vaginal itching, abnormal vaginal discharge and burning sensation when urinating, ruled out because she has no vulvar swelling and no vaginal rash. Urinary tract infection, because of discomfort with urination, ruled out because there's no dysuria and has negative district test. Final diagnosis is a bacterial vaginosis, N77, as evidenced by physical exam, history, and presence of clue cells, pH, and positive FIV test. Diagnostics on 5/6/2022, swab applied to wet mouth for amine test, clue cells test, vaginal pH test. Medications continue her multivitamins, start metronidazole, an antimicrobial, 500 milligrams POBID for 7 days to stop the growth of bacteria, educate about the side effects of headache, dizziness, abdominal pain, diarrhea, constipation, change in taste, appetite, loss of mouth dryness, start Lactobacillus acidophilus 8 billion colony forming units intravaginal for 30 days to prevent recurrent bacteria growth, educate about the side effects of such as bloating, upset stomach, and diarrhea. Non-medications would be recommended to take low sugar yogurt and live active bacteria, which can also help to get rid of the bacterial infection in the vagina. Tea tree oil, it can be mixed with her sesmat because it's an antibacterial properties. Educate proper reproductive hygiene, wipe from front to back, and to keep perineal area clean. Vaginal douches are not recommended. Wear loose clothing and cotton underwear to let the air free, preventing bacterial growth. Referrals not needed at this time. Follow-up plan. A follow-up visit after 2 weeks for a reevaluation. If there is fever more than 101, call the clinic. Go to the ER if there's increased vaginal discomfort, any abdominal pain, or symptoms worse, even after taking medications. Thank you very much.